The following podcast is part of a certified educational activity titled Therapeutic Advances in the Early Treatment of Alzheimer's Disease, Expert Insights on Novel Biomarkers and Emerging Disease-Modifying Therapies. Access the entire activity and complete the post-test at peerview.com/YFY860. Downloadable slides and practice aids are also available.
Hello, I'm Dave Weidman from Banner Alzheimer's Institute in the University of Arizona in Phoenix. Welcome to this educational activity, which is today focusing on therapeutic advances in early Alzheimer's, including recent progress in the development of novel biomarkers and disease-modifying therapies. Joining me in today's discussion is Dr. Danielle Goldfarb, my esteemed colleague from across the Phoenix metro area at Banner Health Research Institute and the University of Arizona. Welcome, Dr. Goldfarb.
Thank you, Dr. Weidman. It's great to be here.
So I'd like to start by stating that the advances in Alzheimer's disease biomarkers have led to really made the field of Alzheimer's explode during the past decade. But these biomarkers really haven't been applied yet to any very practical or broad degree in clinical settings. Despite many well-recognized benefits of identifying early and diagnosing early Alzheimer's disease in an early symptomatic phase called mild cognitive impairment, it often in the community isn't diagnosed until persons have reached a stage of dementia for which our disease-modifying therapies, at least at this juncture, wouldn't be expected to slow down cognitive decline. And we now are seeing, especially with the approval of a drug already, an anti-amyloid antibody, that disease-modifying therapies have the potential to be most effective when they're used early, in early stages, otherwise known as prodromal Alzheimer's. So we think it's very important that neurologists and other healthcare professionals who care for folks who are higher risk, which is mainly age, older individuals at risk for Alzheimer's, and so it's important that we diagnose as early as we can. And we do think that eventually biomarker testing in the community will lead to earlier diagnosis and increase the likelihood that patients will benefit from these disease-modifying therapies. So let's begin with Dr. Goldfarb, and she will present a case.
As clinicians, we always like to make this very real world. So we have a patient here named Stella. She's 62 years old, right-handed female, 18 years of education. So she's had some memory complaints for about 6 months, trouble finding words, misplacing things, also some mood changes with some mild anxiety and maybe some apathy. Her spouse has also noticed she's having trouble with recent conversations and events over maybe the past 2 years, but definitely worse over the last 3 months. And so her medical history just has hypertension controlled on lisinopril. She had a myocardial infarction a decade ago, and no family history of dementia though. So in clinic, she had a mini mental state exam of a score of 25. So she lost 3 points, 3 out of 3 on recall, and then she lost 2 points on orientation for time. And then some other testing that was done. She had some mood questionnaires that showed mild depression and anxiety, and some lab testing for reversible causes of cognitive impairment. Everything came up looking okay. She had an MRI of her brain without contrast that showed mild to moderate bilateral parietal atrophy, a little bit of bifrontal atrophy, and also mild bihippocampal atrophy. In terms of subcortical white matter changes, there was a mild to moderate degree. And so for Stella, her neurologist was considering Alzheimer's biomarker testing. Now there's been quite a significant amount of advances in a variety of biomarkers over the last 15 years. So the majority of biomarkers are still used predominantly in research, but we do have more coming online available for clinical and for also even point of care testing. So many of you may be familiar with this first chart here, which shows the hypothetical change in biomarkers over time for Alzheimer's disease. And importantly to consider the type of biomarker, what it's looking for. So here we have predominantly amyloid beta, tau, and neurodegeneration, as well as finally the last slope here is for the actual clinical change. And on the right side we see another table with the most well-validated biomarkers and we're looking at these in a schema called ATN, or amyloid, tau, and neurodegeneration. So this is a framework that was originally created to try to categorize individuals as having any of these three components as positive or negative, and therefore being able to identify, is someone on the Alzheimer's trajectory or not, and where are they, and what might we do at that point. So we'll get more into detail on these different biomarkers, and you can see these are broken down into CSF, blood, and imaging.
So Dr. Goldfarb, as we can see in this table, there are several well-validated biomarkers, and I was very impressed by the previous slide with the different trajectories, because it brings to light the fact that if the amyloid can start 10 or 20 years before, and then the tau even before symptoms, if we can use biomarkers, an ounce of prevention being worth a pound of cure, then we may change the behavior of clinicians and even, say, community neurologists to think about diagnosing earlier before some of these anti-amyloid and potentially anti-tau treatments will be effective. And what do you think is the best practical way of approaching these different validated biomarkers in the clinic?
Right, so currently, clinically, CSF is covered, reimbursed by Medicare and by other insurance companies, looking for the Alzheimer's panel, so that's the A beta, and the tau, total tau and phosphorylated tau. And so that's for an indication of Alzheimer's disease versus frontotemporal dementia. And so otherwise, these in this table aren't yet online, but we really do expect that. So the amyloid PET scan, we know it has gone through the ideas and new ideas, Medicare studies, and have shown to change management. And so hopefully these will be another tool, and these are really important because there are, in fact, many people who can't have lumbar punctures in this setting. And so you can see that these are really highly sensitive and specific. You and I both, Dr. Weidman, are clinicians, and so we have to be realistic about what's available. But truly, once plasma biomarkers are online, we are going to be using those extensively. And so I just want to put in a plug for all of you practicing doctors that this is going to be happening soon, and we need to consider this for our patients to get early diagnosis. Well, the first paper was published on the amyloid PET scan about 15 years ago, and amyloid PET has increasingly become a mainstay in Alzheimer's research, and truly has shown us that prior to the amyloid PET being available, we were in fact enrolling maybe almost 20% of participants into the Alzheimer's treatment trials did not even have elevated amyloid. And so that it's understandable why some of these trials failed and weren't successful, because a good portion of these people did not even have the Alzheimer's changes. So this has really been a game changer. And as well, we can now detect with this disease in the preclinical stages. And so clinically, when I'm have used this with the ideas or the new ideas study, the Medicare program in clinic, when I have a negative scan in someone who really looks like Alzheimer's disease, then not only is it meaningful to the person and family that, okay, so this is an Alzheimer's mimic, and so perhaps it's one of these, limbic predominant etiologies like a TDP-43, and then when it's positive, it's of course really important too to help really accurately and precisely manage what's going on, and then helpful to direct people to clinical trials who are interested. So the tau PET scan has really been proven to be valuable in aging studies and naturalistic studies, and as a predictor of future cognitive decline, and in therapeutic trials as a surrogate outcome measure. So they're all amyloid positive, but we have cognitively normal, and then the middle group is those who are amyloid positive with mild cognitive impairment, and you can see in their tau PET scan that that elevated tau, the blue there, is much more prominent than in the cognitively normal individuals, and then this progresses as they go into the dementia stage of Alzheimer's disease. You can see the tau burden is present, and and more widespread. And so the first FDA-approved tracer for tau PET was in 2020. So if we switch from PET scans to CSF, which we do have a lot of research, a lot of data, especially from population studies and cohort studies looking at CSF. And we have some really well-validated biomarkers, and those would be total tau, A beta 42, and phosphorylated tau. And a recent analysis did show that total tau to A beta 42 ratio and phosphorylated tau to A beta 42 ratio was actually had a more robust agreement with identifying Alzheimer's individuals than did any one of these CSF markers individually. Now, if you're a practicing clinician seeing individuals with cognitive impairment, you might want to ask, is this person, can I order or look at CSF biomarkers? When should I do this? Who is this indicated for? So any person with mild cognitive impairment that's suggestive of a neurodegenerative disease, possible or probable Alzheimer's disease, and individuals who are early onset, so under 65 years old, as well as those that have some atypical features, such as perhaps there's a behavioral predominant syndrome, and you're really considering, could this be Alzheimer's disease versus frontotemporal dementia. And so in 2018, a group of experts convened and put out appropriate use guidelines for when to use these CSF biomarkers clinically. So that would be good to check out if you're interested. And of note, just recently, the first in vitro diagnostic test, point of care to diagnose or to detect Alzheimer's disease was approved by the FDA. So this is can identify A beta 42 over 40 and has a rapid turnover. So that is exciting that we are making these strides.
Well, we'll move on a little bit to plasma biomarkers. And of course, that's very exciting and new. Dr. Goldfarb, are these available for use in the clinic to confirm Alzheimer's at this juncture, or are they still simply research tools? And how accurate are they?
So they're not available in terms, they're not reimbursed yet. So, but there are some amyloid plasma biomarkers that can be ordered. Are you using them, Dr. Weidman?
Well, the one that's CLIA certified and approved plasma amyloid, I have not used, but I do think that it will be used by me when I think that instead of amyloid PET, I'd want to check for the state of Alzheimer's in someone who may be living too far from a research site, so they can't participate, don't have proximity to a clinical trial where I can check the biomarkers. I also think that it's going to be a great avenue to generate more diagnoses and more interest than in research and interventions in diverse populations. But we also need experience, I think, with this test being available to anyone who wants to pay for it, in how to counsel and interpret the results. So we're not there yet to just recommend this for any physician just to check for amyloid willy-nilly.
And as effective disease modifying treatments come online, this will absolutely be used in a mainstream way and hopefully by primary care providers, although like you said, we will need guidance and guidelines for how to counsel people on these results.
Agreed.
So I'm going to shift now to plasma p-tau 181, which is really one that is going to change the game here to be able to easily and non-invasively diagnose Alzheimer's disease and early, even in these preclinical stages. These are studies that use these ultrasensitive immunoassays to identify p-tau 181. And you can see that they looked at, so let's start on the right side, looking at individuals who are first amyloid beta negative, cognitively unimpaired older adults, and then amyloid beta negative MCI, and next is amyloid beta positive, cognitively unimpaired, and then amyloid beta positive, MCI, and then amyloid beta. In the middle there you see dementia. So there's this sequential increase with the increased cognitive impairment, and then in these other diseases, a nice comparison that there was not an elevation. And then in this other cohort, you can see that similarly this was elevated in MCI and Alzheimer's disease dementia, but not in these other diseases. So what's also really important about p-tau is that it appears that p-tau 181 represents a neuronal response to amyloid beta aggregation. And so p-tau 181 actually is consistent with both tau PET and amyloid PET results. So, which means that if a person has elevated p-tau in their plasma p-tau, that would we could extrapolate. They likely would have, if they had tau PET and amyloid PET, those would be abnormal and elevated too. And so this is really going to make this diagnosis and early treatment and referral to clinical trial actually feasible. And this is already being used to enrich clinical trials and to pre-screen individuals, which is so important because our studies can be long and we have to screen a lot of people. So then more recently, plasma p-tau 217 has been identified, and that appears to be even show an even stronger relationship to Alzheimer's disease, with an increase in those who have Alzheimer's dementia by almost 8 times higher than controls, and then in those with MCI about 1.5 times. And so you can see also in comparison to other neurodegenerative diseases and vascular dementia, we're not seeing an elevation in p-tau 217. And then we can see the area under the curve here is quite high as well. So this is a really important finding in addition to 181. And then more recently, now we have p-tau 231. And so still, this is much newer, so this is also looking promising and increased in Alzheimer's disease dementia and MCI, as well as cognitively normal individuals who have positive amyloid. And so very high performance to identify Alzheimer's disease neuropathology. So it sounds like plasma, p-tau 217 and 231 are all effective at detecting Alzheimer's disease neuropathology. And in the event that all of these biomarkers are validated and approved, how would you select one over the other one, Dr. Weidman?
Well, I'd first preface by saying if all 3 get approved and insurance covered them, that would be an embarrassment of riches as a clinician. And among these 3, and they've even been compared, and there's some literature to support that p-tau 217 seems to perform the best. It's most tightly predictive and matching up with amyloid positivity or elevated amyloid, and in symptomatic folks, then tau PET would be expected to show findings consistent with Alzheimer's disease. I would state that maybe p-tau 231, which seems to elevate first, may be a good screening tool for once we get into population screening for secondary prevention, similar to a lipid panel. But I would be happy with really any of these in the symptomatic phase and enhancing patient care.
So we have now also plasma markers of neurodegeneration that are sensitive. And so we have neurofilament light, which was first identified in CSF. This is a well-established marker for neurodegeneration and is not specific to Alzheimer's disease. But we can see these studies that looked at different cross-sectional cohorts identified that plasma NFL was elevated in not only Alzheimer's disease, but you can see on the left frontotemporal dementia, ALS, and vascular dementia, but not in depression. And so that's a really important finding that we can see here on the right, is that those individuals that had a primary psychiatric late onset disorder, which included depression and also other psychiatrically presenting symptoms like psychosis, did not have elevated neurofilament light, and so therefore this wasn't caused by neurodegenerative disease. So this could be a really important way to quickly determine that. And a lot of times individuals with psychiatric, late onset psychiatric symptoms end up never getting diagnosed, even though it's caused by neurodegenerative disease. They may have a behavioral variant AD or frontotemporal dementia, and so this would be a great way that a psychiatrist, for example, could quickly determine that. So it's always good as a clinician to think about what might be a treatment algorithm in the future, or diagnostic algorithm, and how would we use the biomarkers, the plasma blood-based biomarkers that we've talked about already. And so this is just a potential decision tree that we might use. And so suppose we have an individual with some cognitive impairment who you're seeing in clinic, whether you're a primary care doctor or a neurologist or geriatric psychiatrist. And so you could start with the plasma p-tau. They're older, they have positive plasma p-tau 217, so we really suspect that they have Alzheimer's disease. And so like we said before, they probably if they went on to have amyloid PET and tau PET, those would be positive, and so they could quickly get into treatment. But say this person has cognitive impairment and their p-tau is negative, so then we could check the plasma neurofilament light. And if that one was positive with a negative p-tau, then we might say, okay, they could have another neurodegenerative disease, or they could have vascular dementia, and so we could go that pathway. Or if they had a late onset psychiatric disorder, like we just mentioned, we could do plasma p-tau, and if that was negative, and if they had negative NFL, then we'd know that this isn't neurodegenerative. So there's a lot of exciting possibilities with this, but of course we will need treatments and care to support all of these things once we're diagnosing these more.
So back to Stella, our case of amnestic mild cognitive impairment. An amyloid PET scan was able to be done, and it was elevated, particularly one can see here in red in the frontal lobes. And now management with a firmer diagnosis doesn't so much change, but really expands. Families and the patient can now be informed of the diagnosis and feel proactive about non-pharmacologic strategies, checking with counselors to understand how to plan ahead, how to fill out disability paperwork, appropriate diet, appropriate exercise, and now discuss the potential benefits of a disease-modifying therapy, especially as they become increasingly available. Or very often families and patients are more excited about participating in a trial when they see they have the elevated amyloid. They really want to do something about it. And this wheel is designed to show that there's three types of treatments for Alzheimer's: disease-modifying biologics, which are by and large monoclonal antibodies. Could be against amyloid, could be against tau. There's also disease-modifying small molecules, and then there are symptom-reducing small molecules, which we would add in, say, to donepezil or cholinesterase inhibitor, and hopefully enhance cognition, improve quality of life, even if we don't modify the disease. I want to make sure that you understand that some of this information will be available in a tool format, a practical aid, going through these different monoclonal antibodies that are now in phase 3 clinical trials. Aducanumab has been approved, but there is a study called Embark, which is 3P, open label, which is designed to see whether or not longer use in those who had participated in the pivotal trials is safe and effective. And it's also important to note that baseline Embark data still had here reduced amyloid burden even after that treatment gap between the end of the placebo-controlled studies and the beginning of the open-label Embark study. And there's even a trend that the high dose in the placebo-controlled, here in blue, even after the variable gap period, has a difference in the amount of cognitive decline. And it's important for us to understand there is an increased risk of edema that might develop as we mobilize the amyloid, and even some microhemorrhages And this is greatly associated with ApoE4 haplotype or carrier status. It is usually asymptomatic. We have the most information on this from phase 3 from Aducanumab because that has been published, whereas the phase 3 other trials are still to be read out. So we don't exactly know in larger numbers what the rate is of ARIA in the other, for the other agents. But for Aducanumab, there's an overall rate of 35% for the amyloid-related imaging abnormality edema at the therapeutic dose. And as you can see, are higher in those who carry the E4 allele or haplotype. Most of these people are asymptomatic, but it means that there will be a need for very close MRI follow-up as the doses are being increased up to this therapeutic dose during the first 6 to 12 months of use. Here's just a graphic representation of what ARIA-E looks like in different cases. For instance, if it's this mild and the patient doesn't have symptoms, you could even dose through that. Here, if it's large, and this would be called moderate to severe, then you would suspend the dose. Here's an example of ARIA-H, standing for hemorrhage. These are small microbleeds which may develop here and here, and those tend not to be symptomatic. Very few are symptomatic compared to ARIA-E. Now I'd like to discuss Donanemab in early Alzheimer's disease, also known as the TRAILBLAZER trial. It was the first phase 2 trial to show a disease-modifying effect with a significant trend towards benefit in slowing down cognitive decline. Donanemab was also unique in that it was the first trial to enroll patients based on the extent of the tau pathology, such that patients with no or very low tau here, who may even be amyloid positive but yet have symptoms, were excluded because they either would not really be deemed to have any natural progression during the feasible duration of a trial, or perhaps even the symptoms would not be considered due to Alzheimer's disease without sufficient tau burden. And the folks with high tau were excluded because they perhaps would be viewed as too advanced to be slowed down by anti-amyloid therapy. The primary outcome was a combination of a functional and cognitive scale, and then there's clearly a trend towards slowing down of cognitive decline throughout these 76 weeks. Similar trends were seen in other secondary outcomes. This is another combination of cognition and function. Clearly very strongly removed amyloid, in fact, so much so that there were 25% of people after 6 months and 50% of people who received drug after 12 months had enough amyloid cleared to be quote-unquote amyloid PET negative or in the normal range, such that they did not even need further Donanemab over the 78-week trial and were switched to placebo in a masked fashion. The AAN meetings have reported and confirmed that both plasma phosphorylated tau 217 and glial fibrillary acidic proteins show a decrease in response to Donanemab. And the new fact here is that this is a sustained lowering, both in the Donanemab group that continued after 24 weeks and the Donanemab group, as I had mentioned, who after half a year had sufficient amount of amyloid to be removed. So an implication of this is that there was a prolonged effect of lowering amyloid, and there was also not seen here a sustained reduction in the amyloid burden. It clearly seems to affect soluble forms of phosphorylated tau. The TRAILBLAZER-2 study design, and don't be confused, the TRAILBLAZER-2 is the phase 3 study, is enrolling a much larger number of patients. It has stopped enrolling. The difference between this study and the phase 2 is now that the patients with high tau burden by PET scan would be allowed to receive treatment, even though the primary objective and outcome is to see whether there's slowing down of cognitive decline in the intermediate group, as in the phase 2. There'll be a sub-analysis of those who have high tau burden to see if there's clinical efficacy there as well. low tau burden patients are continuing to be excluded, and again, the main reason for that is feasibility, that they would not be expected to be to progress a placebo or drug within the feasible duration of these trials, which are very expensive. TRAILBLAZER-4 is a head-to-head study comparing donanemab to aducanumab, really to see whether or not this effect that I described with donanemab removing amyloid very quickly over 6 to 12 months is unique, or is this the case with aducanumab as well? So there will be a direct comparison.
So, Dr. Weidman, what do you think the implications of this study, this head-to-head study, will be depending on the results?
I think this could be a landmark study in the sense that should donanemab be unique in this way, then we could consider, if it is proven to be clinically effective, shows efficacy in slowing down cognitive decline, and say as prescribable as aducanumab is, then we would have a sense of a more limited duration of therapy. Right now with aducanumab, there is no stopping point that we know of. There's not enough evidence to know when to stop administering. So at this point, it could be potentially indefinite.
And certainly that leads to important cost considerations when there's concern about bankrupting Medicare with these treatments. So that's really crucial.
Yes, great point, Dr. Goldfarb. Donanemab, based on some previous studies which did not meet primary efficacy endpoints clinically, still removed amyloid in a very potent way, slowly and gradually over 3 years. These studies, while they were failures of phase 3, still were, showed subgroups of persons who had received the highest dose were now showing some trend towards slowing of cognitive decline, such that there are now ongoing trials, now in the open label extension phases, meaning no one is on placebo eventually, called Graduate 1 and Graduate 2, where subcutaneously there is, over the first 6 to 9 months, a titration towards doses that seem to show a trend towards clinical efficacy in the previous trials, such that everyone will now be on this higher dose. And there'll be a readout later this year to see whether or not this is efficacious and safe. Lecanemab is yet another player with a readout, and this slide is showing the phase 2 evidence. I should emphasize that this trend towards a lowering of or slowing down of cognitive decline is only in the group in the phase 2 that was titrated up to 10 milligrams per kilogram biweekly or twice a month. Like aducanumab, during a treatment gap, there was still a maintained lowering of amyloid burden and a continued slowing down of cognitive decline. But again, these are very small numbers, as you can see here, way less than 50 here overall in that high treatment group. So the jury's out on whether or not lecanemab is modifying a disease at this dose, but we'll get a readout later this year. And here is that lecanemab trial, where folks are given 10 milligrams per kilogram biweekly. I do want to conclude with CMS, or Center for Medicare and Medicaid Services, coverage policy decision that aducanumab would only be covered in the context of a clinical confirmatory trial or through a CMS-approved study using data collection through a registry. The concept is that Medicare sometimes covers agents only through evidence of development. And another point is that this may not be applied to all anti-amyloid therapies. If the other monoclonal antibodies that have readouts soon show a clinical benefit, a registry may suffice, but they may be covered by Medicare. There may be, in other words, no binding by class by CMS. But this is the case with aducanumab. Persons, again, there are several reasons why persons were against this CMS type of coverage decision, including compromising patient access and worsening present inequities. but in my view, in my humble opinion, these types of new restrictions are the safest approach. And CMS wants to answer these questions: whether the clinical benefit is replicated in the general Medicare population, whether certain subgroups experience different benefits and harms, and how those benefits and harms change over time. This was a great discussion on the recent progress being made with Alzheimer's biomarkers and the exciting developments that are emerging with positive biomarkers, in particular, as Dr. Goldfarb reviewed so nicely. And I hope you have a better understanding of where we're at with monoclonal antibodies, which are anti-amyloid, and in late-stage development with readouts in 2022 and 2023. Before we conclude the program, please make sure to review and download the resources that we mentioned. Feel free to share them with other clinicians and healthcare practitioners who care for patients with mild cognitive impairment and early Alzheimer's disease. And that ends our discussion for today. Thank you again, Dr. Goldfarb, for your insights.
Thank you, Dr. Weidman. This has been a great discussion. I'm so excited about what's happening in this field. We're really moving from, I hope everyone is picking up on this, from a clinical diagnosis of Alzheimer's to a biologic diagnosis. And so this is going to open up developing diagnostic and treatment algorithms and really a much more nuanced understanding of this disease and these diseases.
Well said, and thank you all again for participating.
Thank you for listening. Download materials and complete the post test for instant credit at peerview.com/YFY860. This activity is supported by an educational grant from Lilly.